Welcome to our channel. Dr. Praveen Gupta presents Oncology Nursing Conclave 2026.
So today I'll be talking on radiation oncology, a general overview. In the end of this lecture, we'll be able to tell what is radiotherapy, which cancers require radiotherapy, the RT treatment journey faced by a patient, and side effects which we have to monitor and your critical nursing role in that. If we talk about impact of radiotherapy, so 50 to 60% of all cancers patients require RT during their cancer journey. 40% of cancer cures are because of radiotherapy. It has a more curative contribution than chemotherapy, which has only 10 to 15%. In India currently, because of lack of access and many other things, there is a gap of 30% in patients receiving RT. RT can be used in so many roles like curative treatment for curing cancer, in adjuvant therapy after surgery to reduce chances of recurrence, in neoadjuvant setting before surgery, in palliative setting. So what is radiation? Radiotherapy uses high energy ionizing radiation to destroy cancer cells while minimizing damage to surrounding healthy tissues. Brachytherapy has already been discussed. So external beam is fighting cancer from outside the body using a LINAC, and brachytherapy is using radioactive sources. So if we talk about cancers requiring RT, most common is cervical cancer in almost 95%. Then there are so many other cancers you can see. So radiotherapy saves millions of lives every year, yet many patients fear it unnecessarily. When we talk about the science behind it, there are two types of things. One is direct DNA damage, second is indirect DNA damage, and the result is DNA damage and cancer cell dies. Why we give it in multiple fractions for 5 to 7 weeks? There are so many reasons. These are typical 7 hours of radiotherapy. Repair, reoxygenation, redistribution, repopulation, radiosensitivity, and others. So patient has 4 stages of radiotherapy treatment. First is CT simulation, which takes around 30 to 60 minutes. Then there is treatment planning, which usually takes 1 to 2 days. Then there is treatment delivery for 5 to 7 weeks, and there is a long-term follow-up. So first, when patient comes, we have to set up the patient so that it matches accurately over time, and a thermoplastic mold is made so that we get same position every day for accurate targeting. Then second comes the creating perfect plan for the patient. It requires a medical physicist who design the beam angles and dose distribution, and a radiation oncologist to actually draw and contour the target volumes, OARs and others. Third is daily treatment, which usually takes 10 to 15 minutes. There is patient setup, then image guidance using CBCTV match previous image to the current image, and then there is treatment delivery, which takes around 2 to 5 minutes. Patient feels nothing. So we have advanced technologies at BMCHRC like IMRT, IGRT, SBRT, SRS. This has already been covered by Sony sir, so I will not be talking about this brachytherapy. Nursing responsibilities have already been told, like we have to counsel the patient, take consent, ensure bladder and bowel preparation, anesthesia coordination. Then during treatment there are some radiation safety protocols, time, distance and shielding principles, and we have to monitor patient comfort. And then post-procedure also, we have to remove the applicator carefully, assess for bleeding and discharge instructions. So there are some acute side effects which come after 2 to 4 weeks of RT, and there are some late side effects that come later. In acute, if we talk about site specific, in brain RT we can see headache, hair loss in the treatment field, and fatigue. in mainly head and neck RT, there is mucositis, like we can see in this picture, grade 2 and 3 mucositis. There is xerostomia, there is taste changes, there is skin problem also. In breast RT, there is skin erythema, lymphedema, and others. In other sites also, like chest RT, we can have esophagitis. There are lungs in the field, so we can have pneumonia-like things. In pelvis RT, there are bowel loops, so we can have diarrhea. There is bladder, so we can have cystitis, and also skin irritation at these sites. So late toxicities are also there, which come after 3 months, and it is also side-specific. It is a local treatment, so only local side effects are there. Like in brain radiotherapy, we'll have some brain area necrosis. In head and neck, we can have dental caries and subcutaneous fibrosis and xerostomia and others. In breast, we have lymphedema, chances of rib fracture, and also there is heart nearby, so some cardiac toxicities also. In chest, we have pneumonitis, pulmonary fibrosis, etc. In pelvis, already bladder and bowel problems. And also there is 1 to 2% chances of secondary malignancy risk, of which most common is sarcomas, which occurs usually after 10 years of radiotherapy. And these late effects are permanent, so counseling is very important, so that patient don't tell us in the last that you didn't tell me about this. So what we and you guys as a nursing, what we have to do and counsel the patient. First of all, skin is being irritated in almost every case, so gentle cleansing with lukewarm water is done. Pat dry, don't rub the skin because skin is sensitive. Rubbing it may cause it to remove. Then moisturize with non-fragrance, non-petroleum creams. Avoid sun exposures and tight clothing. No deodorant used during the breast RT. And grade 3 moist desquamation, we can use hydrocolloid dressings also. For mucositis, which is a main problem, it causes weight loss in the patient and very common reason of death also. So oral care protocol is salt and soda rinses every 2 hours. Avoid alcohol-based mouthwashes. Patient most commonly use Listerine or chlorhexidine, which is a alcohol-based mouthwash. So we advise more salt and soda rinses and other things. For pain medication, we can give local anesthetics, and for nutrition, we have to look specifically and advise PEG tube or rice tube or Frega tube for the nutrition. In cases of pelvic RT, we have diarrhea also, so we advise low fiber diet, lactose-free diet, sitz bath for perineal irritations, and some barrier creams. For fatigue management, there are some light exercises, and also nutrition is very important for this. For nausea, we usually give antiemetics, small frequent meals, and acupressure, and some have been tried. So why nurses make all the difference? From the starting point, patient education and communication is mostly dealt by nursing staff. Explain treatment in simple, non-medical terms. Address fears of the patient, like radiation exposure is not a hazard for their family. Set expectations about the side effects which are going to come and how we will assess them. Then toxicity monitoring, CTCA grading and all. Then some supportive care coordination for weight loss, symptom control and skin reactions. Then there is one more important thing, radiation safety education. Like in EBRT, there is no risk to family or public. In brachytherapy, there are certain safety protocols we have to follow. Now, key radiation safety points. So basically, there are most important 3 things: limit exposure time, keep safe distance, and third is use shielding. And other things are proper protocols should be followed, PP, education and training of the staff and the patient and their family members also. So main critical points we have to remember is RT cures cancer, treatment is painless, side effects are manageable, education reduces fear, and nurses are essential to success for this. Thank you.
Thanks for attention. For more educational content, subscribe the channel.